Hey guys, how's everyone doing today? Good. All right, guys, think back. It's spring break. You're sleeping and dreaming about the endless possibilities for the week. When suddenly, your mom calls you and wakes you up. Hello, come to Emory Hospital immediately. Your dad had a serious case of vertigo this morning, and the doctors found a tumor in his forehead. Your heart stops. Is he going to be okay? We don't know yet. You don't know anything about cancer. You only know about the horror stories that come with it. And you find yourself sitting, worrying over life and death. Hi, my name is Sanjit Kumar. I'm the founder and CEO at DiaScan. The buzz is everywhere. Everyone is talking about how artificial intelligence and machine learning will completely revamp healthcare and how medtech is going to be the next big thing. So we use machine learning and computer vision to analyze lung tumors on CT scans. So we hope to bring machine learning to medical imagery to help radiologists and doctors by providing remarkable insights and automating tedious processes and tasks. So as I mentioned, our current focus is lung cancer. Why? It's the number one cancer killer, even though it's the second most common type of cancer. To put it in perspective, every year around 220,000 Americans are diagnosed with malignant lung cancer, and 160,000 of them unfortunately pass. So you can see the numbers are absolutely huge, and there needs to be a call for change. So why does this occur in the first place? Well, it all comes down to the way that we diagnose lung cancer initially. For any given tumor, there's a less than 10% chance that that tumor will be malignant. Yet, initially, everyone is treated as if having a malignant tumor, even though it is most likely benign. Now, this leads to a very high false positive rate. 96.4% was our first number that we found whenever we looked at the NLST study, a very popular study that was conducted by the National Lung Screening Trial. And this leads to a lot of unnecessary follow-up procedures such as biopsies and repeat CT scans. Biopsy is expensive, invasive, prone to complications, and repeat CT scans can lead to radiation poisoning. Now, if you have a malignant tumor, obviously it's going to be very hard, mainly because they can only diagnose you as malignant once the tumor grows large enough. And this leads to metastasis, or the cancer spreading around the body. So why does this occur in the first place? Why are there so many problems with diagnosing? Well, that's because there are a lot of problems with analyzing initially. The current analytical methods for analyzing a CT scan are very outdated. There's no automation of tedious tasks. There's a low nodule detection rate for CAD systems that can look at the tumor, and there's no machine learning or predictive analytics involved in current standards. These lack of proper analysis leads to misdiagnosis, and better analysis can help patients by reducing the amount of unnecessary follow-up procedures and alleviating a lot of the unnecessary expense and pain. So when we tell people this, they ask us, why can't radiologists just tell the difference already? They go to med school for such a long time. Is it really that hard? Well, yeah, because no human eye can really detect the slight nuances that differentiate between a benign and malignant tumor. There are just so many different things to look at, just the intricacies of it all. When it comes to spiculations, calcifications, density and size, axis lengths, eccentricity, orientation. Humans can't really do this, but a machine can. DiaScan can. Our product is a risk assessment tool that leverages machine learning and computer vision on CT scans to analyze lung tumors. We assist radiologists by automatically calculating tumor characteristics using computer vision and throw everything into machine learning algorithms to find patterns in the past data and apply it to current data and really help differentiate between benign and malignant tumors with a % accuracy. So we were able to do this by obtaining 10,000 patients around from the National Cancer Institute and created a cloud-based web application creating backend APIs so we can automatically input medical data, extract important features, and use machine learning to really use this and use the past data and find these patterns and automatically generate a very good report for radiologists that includes the quantified features and a percent confidence level of benign or malignant. So these are all the features that we extract. So all the ones in white mean we extract them already. In blue, we're working on them. We're working on a mathematical means to extract this information from the CT scan. So how accurate are we? So far with our preliminary testing, we've been able to achieve a 92.3% accuracy level when training with patient data and image data. So the reason how we got this, we used a holdout validation technique, holdout of a 25%. So we trained with 75% of our data set and tested on the rest 25%. And when we just use the image without any patient data, we're able to get over 80%, which is still a great number for us. Now, current standards are around 5 to 10% whenever in the actual, current for practicing. But in reality, there's a 50% baseline if you just were to guess one or the other. So that's how we hope to achieve 50%, and we're able to really achieve way higher than that benchmark. So far, our user interface, we've been working very hard on our design. We want to make it very easy to use and have a great looking dashboard for the radiologist to use. So with this, the radiologist will easily be able to add a patient, and it'll be accessible from anywhere. So the market size for a product like this is absolutely huge, and we find ourselves within having a good niche between the lung cancer imaging tests and CT analysis software, which are 900 million and 400 million respectively. So there are a lot of companies starting to do a lot of things very similar to this. So, the bigger companies are going to do it as well. For startups, Analytic is probably our biggest competition. They're based in California, and they raised a $10 million round last year, I believe. But we're more different because we have a specific lung cancer focus, and we're planning to be a risk assessment tool rather than a full diagnostic, which will help us with FDA clearance rather than getting a FDA approval as a Class 3 medical device. So far, what we've done, we were accepted into Cyber Launch Accelerator last year, where we raised our first pre-seed round from Mr. Chris Klaus, who's heavily invested in Georgia Tech as well. We've been collaborating with the NCI for over a year now. We've been invited to present at the International Conference on Radiology and Imaging in Las Vegas. We got the Audience Choice Award and third place at TechCrunch just last February. And we were top 5 in the Atlanta Startup Battle back in November. As well as that, we've been featured in Hypotemus, Atlanta Magazine, and much more to come. So the founders, me and my partner, CTO at Berkeley, and we have 3 others, from Georgia Tech, UCLA, Berkeley, and UGA. We know that we're not experienced. We're all college kids here, but it's really our mentors and advisors that take the cake. Dr. Badrshen Vikram, who is the Nobel Prize winner and the chief of the radiation oncology branch at the NCI. Mr. Chris Klaus, who's the CEO at Caneva right now, but he also sold his company to IBM back 10 years ago for over $1 billion. Dr. Sam Franklin, who's the VP of data science at 360i in Atlanta. So thank you so much for listening to me. I know we're all tired right now, but we hope to use machine learning, computer vision to help the world be a better place. Thank you so much.
So your financial model, did you miss a slide there? I saw there was one you may have jumped over. Was it?
It was that was for if we. I accidentally forgot to take out one of the slides for if we were to raise a round. Okay. So that's not really that's more of a like a step by step what we're going to use what we would have used the money for when pitching to investors. But yeah, sorry.
So tell us your financial model. Is it are you doing as a tool for radiologists, I guess, to yes. pre-screen, and I've had some investments in that space before, but is it what's your financial model? What do you charge a radiologist? What's the is it
So even though radiologist is going to be our end user, we're not going to be selling directly to radiologists. Our plan is to go through CT scan vendors. So companies like GE, Siemens, Toshiba, Philips, they're looking for a lot of companies to integrate their hardware with our software. So for example, Samsung just acquired Neurologica, which is a portable CT scan company. They also make portable MRI machines. They've been looking for everyone. We've been talking to them as well. So it all really just depends on who we're able to sell to. But yeah, CT scan vendors are our go-to because they're the ones who create the scans in the first place, essentially.
And do you have a working prototype? I mean, do you currently take scans? You do the visual, the density, it all from a computer standpoint. It highlights these areas you need to look at. This may be.
So for highlighting, we're not there yet, but yes, everything else apart from just the feature extraction, the machine learning, we have a beta model, and we're planning to have a full version 1 done by the end of the summer and start pilots then.
When you said the 82% from a success rate, just with the images without patient data, is that using your prototype or?
So basically, the patient data that we take in that increases our accuracy is stuff like age, ethnicity, smoking history, lung cancer history, like family lung cancer history. This is all information that is found within the PAC system. So essentially, what's able to happen is that whenever we do roll out products for pilot testing, because all of this is non-PI information, we'd be able to use it when actually using our product in the first place. So when we did the 2 different types of testing, it was just for preliminary to see how much the patient data affects the overall accuracy. So essentially, that 82% isn't really our benchmark. It really is up that 92% is where we stand.
Right. And have you raised any seed money at this point?
Yes. When we raised our pre-seed round last year, we raised $20,000 through the accelerator.
I'm trying to understand how you get enough data, enough scans to make the AI really work.
Yeah, so all of our data is from the National Cancer Institute. We have both their private and their public data set, which is around 10,000 patients. Everything is completely verified, completely labeled, by doctors all around the nation multiple times. So we have a bunch of information about not only the patient but about the scan itself. So that's how we are able to learn from.
I still don't quite understand the financial model. So if you sell to the people providing the scan services, how do you charge?
So we'll be charging on a per scan basis. So our plan right now is there are around 4 million scans done every year. If we were to be able to get 10% penetration, for example, 400,000 scans, within 1.5 to 2 years of selling, that's 400,000 scans. If we were to charge 10% of what a CT scan, like how much that costs, which is around $1,000, it's $100 times 400,000, which is 40 million. Which is this is like thinking on a pretty big scale already. And again, there are also many different ways to sell. Just going around not only hospitals but also CT scan vendors. Also, we've already been talking to a lot of medical software companies who have image viewers essentially, and they've been looking for a product like ours to integrate within theirs, and we can do rev share models that way. So yeah, our financial model it really depends on what the consumer wants, as well as what these other companies who want to license from us want as well.
Yeah, I just think that industry is a slippery slope on how you pass more costs through, because ultimately it's going through to an insurance provider or a private pay or something, and how does the cost structure work? So
definitely, yeah. I mean, the medical industry is always very, very hard, to go through. Especially even when we obtain FDA clearance, it's still going to be very difficult to reach the consumer and really get them to use this product. That's always been, but sorry.
understand the value.
Yeah, and that's the thing. I don't agree with that at all, and it's mainly because we look at Facebook, we look at all these social media, for example, and they have technology, they use technology that the medical field just hasn't adopted yet, and that should be the opposite. The medical field should be the highest, the most advanced technology ever, and it's people's health. It took my dad to have cancer, and we realized that health is the most important thing in the world. But I guess we're out of time. But thank you guys so much again.